So my name is Anita D'Souza. I'm a plasma cell disorders focused hematologist, oncologist, and clinical researcher. So in my practice, I mostly take care of patients with all kinds of plasma cell diseases. These include precursor diseases like monoclonal gammopathy of undetermined significance or smoldering myeloma, to the end of the spectrum, which is patients with diseases such as multiple myeloma, light chain amyloidosis, plasma cell leukemia, and a smattering of other rarer plasma cell disorders. Things that I do during my research time include clinical trials, as well as outcome and health services research. Multiple myeloma is a common disease as we look at all kinds of blood cancers. It's the second most common blood cancer, but the most common if we look among African Americans. And to this day, it remains an incurable disease. So even though in the last 2 to 3 decades, we've had lots of therapies that have gone through the clinical research pipeline and have been FDA approved, this remains an incurable disease. And what that means is the more options we have for our patients, the better it is. And it has been really great to be part of this journey and just seeing the number of new therapies that have come in, gone through the various phases of clinical trials and have led to FDA approvals. In the ASH presentation that I did, I have to clarify that this was not the primary results of the MajesTEC-2 or the TRIMM-2 trials, but rather a pooled analysis of one of the combinations that were studied during these trials. So during this year's ASH, what we had looked at is among these 2 trials, the patients who had received a very specific teclistamab combination, which was teclistamab along with the anti-CD38 monoclonal antibody daratumumab and pomalidomide, which is an immunomodulatory drug. Both daratumumab and pomalidomide are parts of our mainstay of myeloma therapies. And in this pooled analysis, we looked to see how did these 2 drugs combined with teclistamab, what additional value did they bring in for our patients with relapsed or refractory myeloma? Before I provide the findings, there were some key differences in these 2 studies in terms of patient eligibility characteristics. So MajesTEC-2 patients were slightly earlier in their natural history. So these were patients who had had 1 to 3 prior lines of therapy, whereas in the TRIMM-2, the eligibility requirement was that patients had to have had at least 3, if not more, prior lines of therapy. So the TRIMM-2 patients were just slightly more pre-treated. So they tend to be having just a little more aggressive disease. We saw a little more extramedullary disease. These patients had had more prior daratumumab or even pomalidomide exposure. And we had, out of the total 27 patients that we studied in this analysis, 17 came from TEC-2 and 10 from TRIMM-2. And what we saw is that this combination was effective. We saw really good overall response rates, good complete response rates, definitely higher than when you use teclistamab as a single agent in this setting, or even combined with daratumumab. But additionally, what also came with this increased efficacy was just a higher infectious signal. So there were more neutropenias, there were lots of infections. And when I say infections, I also want to put this in the context of the timing of this trial. So both these trials enrolled patients. One of them was in 2020, and then they went on into 2021. And the other study was totally in 2021. So putting it in the context of the COVID pandemic, we did see a lot of COVID infections, and as well as the longer follow-up that we have available. The total follow-up we have is over 2 years. So we definitely saw greater infection density. And this was the time when we weren't fully aware of all the risks associated with BCMA bispecific therapy, which is the very high incidence of hypogammaglobulinemia. So nearly all the patients treated on this study had hypogammaglobulinemia, which was defined as an IgG level of less than 400 milligram per deciliter. And in keeping with this high hypogammaglobulinemia, we did see that 6 patients had infection-related deaths, 4 of which were related to COVID-19 infection and pneumonia. 1 patient from another pneumonia, we don't know what the pathogen was, and then an additional patient with pseudomonal bacteremia. And 4 of these 6 patients who died of infection prior to their infection did have hypogammaglobulinemia and were not receiving IVIG. So as these data were coming in, as well as data we were understanding from other bispecific trials, very strict infection mitigation strategies were put in place. They were strongly recommended to institutions that had these trials open, especially with immunoglobulin replacement, either intravenously or subcutaneously. And since doing that, no additional deaths were seen. So I think what that tells me is that, yes, this combination is an option. It has efficacy, it has good responses. The responses appear to be durable, but it has to be done with very strong consideration for these infection mitigation strategies. And the main one of which is making sure IgG levels are being checked and that patients are getting immunoglobulin replacement based on their immunoglobulin levels.